This lecture is a continuation of a discussion of etiology or causes of child maltreatment. And we will be discussing microsystemic and ontogenetic issues. When we speak of microsystemic risk factors, we're discussing the family and often the classroom factors. Today's lecture will focus on family factors that we know increase the risk of child maltreatment, such as social isolation, parental mental illness, parental history of child abuse, child rearing beliefs and practices, other parental limitations such as developmental disability or health issues, domestic violence, and parental substance abuse. Social isolation is a risk factor, but the research says that we have to look at this in a focused way. There are many questions that come up when we look at social connectedness in families. There might be families who appear to be connected. However, when you look at the appropriateness of the extended family members and friends, there are not a lot of safe, protective kin keepers. Extended family are not always reliable as caretakers. There also may be people in and out of the home, and the living arrangements may be quite unstable. So the question is whether in this network there are people that the family can rely on, and whether or not these people enforce positive parenting practices or not. You can have a family that is not isolated and is very connected, but has many negative influences from those people who they rely on for support. So while social isolation in general is a risk factor, again, we must look at whether those families who are not isolated are supported in an appropriate way. Parental mental illness is often, again, cited as a major risk factor for the development of child maltreatment. Major psychiatric conditions such as schizophrenia or bipolar disorder, as well as what are called characterological problems, or personality disorders such as borderline personality disorder increases the risk of child maltreatment. The real question, however, is not the diagnosis, but the individual's understanding of their condition, the understanding of the relationship to their ability to parent, their ability to follow their treatment plan, medication compliance, therapy, anything that has been recommended by their treatment providers to support and stabilize their symptoms, in addition to having social supports. So there are a lot of people who are diagnosed with severe mental illness who can lead successful lives and can be good parents if the questions we just discussed are addressed in a positive way. You cannot generalize that if someone has a diagnosis, they cannot parent. We have to look at many other factors before making that determination. Another major factor creating risk in the nuclear family is whether the parents have a history of child abuse themselves. Towards the end of the semester, we are going to be looking at this issue further as we discuss intergenerational transmission of child abuse. But we know, first of all, that child abuse can lead to many mental disorders. As we discussed previously, mental illness might increase risk of child maltreatment. Mental health issues also increase the risk of substance abuse, which we'll talk about momentarily. And substance abuse certainly increases the risk of abuse and neglect. If you've been abused as a child and you're now a parent, you may have difficulties being able to attach emotionally to your child because a history of child abuse most likely has led to attachment issues. We'll be talking extensively about attachment issues and what that means in another module. But it's important to understand that there might be an impairment in someone with a history of abuse being able to attach appropriately to their own children. And finally, if you've been abused as a child, you really don't have any notion of what is appropriate parenting. This might increase, of course, the risk of child maltreating behaviors for a number of different reasons. Child rearing techniques that are used by parents can raise the risk or can buffer the likelihood of child maltreatment. The literature on child maltreatment and its risks talk a lot about child rearing practices and the kinds of parental behaviors that have better outcomes and the kind of behaviors that have more risky outcomes. In general, the literature seems to be talking about two types of issues that parents have to engage in to be effective and to reduce child abuse and neglect. The first issue is responsiveness, and the second is demandingness. When we're talking about responsiveness, we're talking about a range of different responses. You'll see different words used in the literature. But basically, what we're talking about is the ability of the parent to engage in a relationship with the child so that there's some reciprocity, some synchrony, some ability to engage in a back and forth relationship, give and take. It typically involves warmth, the ability to stimulate a child and to be verbally responsive, to attach to a child, for the child to feel unconditionally accepted as a person, not necessarily their behaviors, for the parent to be involved, and for the parent to take the child's wishes and feelings into account in the relationship. Demandingness is the second major dimension, and it's again described differently in articles, but it's basically the ability to set and enforce expectations and limits. To persist in demanding something even if the child doesn't like it, to be able to get the child to comply, to monitor what the child does if you set a limit, and to be able to monitor and constrain the child's activities, particularly if the child is in some type of danger. The classic literature in this area has looked at demandingness and responsiveness as two different dimensions. And so you may see in articles or in the text the discussion of permissive parenting practice styles, authoritative parenting practice styles, disengaged, and authoritarian. The notion, if you look at this chart here, is that permissive parents are often low on demandingness and high on responsiveness. So they're very present and very involved, but they don't really expect much from their children. Disengaged parents are not present and involved, so there's a low responsiveness, and they're not really too demanding. There's a low demandingness. When you look at authoritarian parenting styles, these are parents who are not very responsive to children emotionally, but are very high on demandingness. And then you have authoritative parents, which is described in the literature as the best kind of parents, and they're high on demandingness and high on responsiveness. So in the classic parenting literature, authoritative parents are seen as producing independent, motivated, self-sufficient, but emotionally secure children. This is seen as being the group with the lowest risk of child abuse. Obviously, authoritarian parents are seen as being at high risk of physical abuse in their attempts to make high demands with not necessarily showing empathy or responsiveness to children. And there's Snickers, my cat, joining us today. Excuse me. Disengaged parents are at higher risk for neglect because there's not very much of an involvement in either making demands or giving much emotionally and socially to children. And permissive parents are highly indulgent, and though not typically abusive, they're not necessarily raising children who are functioning in the optimal way. Now, it should be noted that these are stereotypes, and these are not necessarily true in every situation. There are cultural issues as well, in that situations when people are very highly stressed and living in dangerous environments, as we spoke of in the lecture on the macrosystems. Authoritarian parents may actually be the best parenting style for that situation. For example, if their demands are to protect children, this may in fact be effective and be a compensatory factor. This is particularly true of African American parents, and living in a racist society, the expectation for obedience may actually have an adaptive quality. So effective parent training programs typically teach responsiveness and demandingness, how to do both, and how to understand. A very important factor is to teach parents how to understand the developmental needs and limits of a child and what is appropriate at each developmental stage. Other parental limitations can also be risk factors for child maltreatment. For example, a parent who is disabled in some way may not be able to monitor the child, set appropriate physical boundaries, and they also may not be able to be responsive to the child if there's cognitive delays. A lot of this does depend on the developmental level of the child and has to be assessed based on that and any special needs the child might have. For example, the younger child will need more attention than an older child. And similarly, the resources will make a difference in whether parental limitations are a problem. Disabled parents who have good family support do not present with much of a risk factor, whereas parents who have families where there is not a lot of support, they are definitely at higher risk. The question of domestic violence is a major one in the child abuse field. Domestic violence is an incredibly high-risk situation for children, and it is important to understand what domestic violence is a bit. When we talk of domestic violence, we can talk about incidents that run across a variety of dimensions. We may speak of a situation where there's chronic domestic violence going on, and other situations where there is episodic or isolated incidents. In addition, we may come across situations where there is violence that happens between both people. Both people participate, it is bi-directional, and it may be started by either one, or violence that is unidirectional, which is typically the classic battering situation. The relationship between the participants may vary. You may have domestic violence situations where there are good supportive aspects of the relationship in addition to the violent episodes. And then you have relationships where the entire relationship is problematic. So it's very important to recognize that these are complex situations and do not call for a single response. Despite whether it's bidirectional or unidirectional, in general, women get hurt more, and so children, because they're very small, are likely to get hurt as well. One of the things that I would call your attention to is that even though the incidents may be isolated, there may be chronic dynamics in the family. So that may include repeated physical confrontations, but might also include threats of physical violence. Particularly in situations that are the classic battering situations, you have constant psychological demeaning of women. This often has a sexual quality, and the woman is characterized as being promiscuous or loose, being a whore, and possibly, most importantly, something the children would be very aware of in the relationship are the attempts at isolation and control of the woman on the part of the batterer. This is often expressed in terms of jealousy, in her interests, and even contacts with other men, even men that might be strangers. There may be an insistence of her accounting for where she goes, not giving her money to spend, not allowing her to have contact with family or friends, and these are all witnessed by children. So even if kids are not necessarily witnessing direct physical confrontation, they are affected greatly by this dynamic, the controlling dynamic. In addition, children also witness abuse of pets. We know now from the literature that abuse of pets often goes hand in hand with both domestic violence and child abuse. So again, these dynamics are often important to recognize even though there may not be accounts of direct physical violence. When we talk about domestic violence, particularly chronic domestic violence, we are often talking about a cycle of behavior. Somewhere in the cycle is a violent episode, and that would be an actual physical incident of abuse. And after the violent episode, there's typically a period of guilt, asking for forgiveness, begging for forgiveness, sending flowers and cards. Somehow the abuser tries to make it up to his victim. And then it slides into the honeymoon stage where things are stable, some relationships are supportive, and everything seems to be okay. And then it goes back to the escalating tension building stage. The end of the cycle is often very stressful for the women and children who are aware of the cycle. This is a period, short or long, in which the batterer becomes more angry, more controlling, and the mom and women and children, and again, we're talking about the classic battering situation. There's obviously domestic violence that occurs within same-sex couples. There's obviously domestic violence that is perpetrated by women towards men. We're just speaking in general about the classic battering situation that we see, which is the man perpetrating against the woman. We've actually had reports of women who will say that they deliberately provoke a violent episode so that they can escape this tension and move through the cycle further. When we talk about witnessing domestic violence, we're talking about a range of behaviors. Children might actually witness the physical confrontation or the sexual confrontation. Children might overhear the violence that's happening. Mom and dad think that they're asleep in their room, but they are crying in bed listening to the fights that are going on and the arguments. Children might hear about or see the after effects of an episode. Mom might be on the phone talking with somebody about it. The parents might discuss it the next day. Mom might have injuries, a black eye. There might be some physical damage in the home. And also just living in the household with the domestic violence dynamics, which I spoke of earlier. This has a profound effect on children. There are effects that are direct or indirect. Direct effects are the direct physical, emotional, and behavioral problems a child may experience as a result of being present when domestic violence is happening. Because domestic violence takes a toll on the mother in the classic battering situation, and there's typically also a problem with the father, the result is an impairment in parenting. So in typical domestic violence, the problems we see in children can come from one or both of these factors. That impaired parenting may continue even if the domestic violence itself stops, particularly if the dynamics of the interactions remain the same, such as the controlling jealousy, the controlling and demeaning behaviors, and the extreme jealousy. And this will certainly affect the ability to parent children. It's very important to recognize, first and foremost, and certainly the Division of Youth and Family Services is very aware of this, is that domestic violence raises the risk of child abuse. Sometimes children will get caught in the middle by accident. They might get injured while trying to intervene in a fight between the mother and the father, and obviously the witnessing to the violence and the after effects can be incredibly traumatizing to children. It's important to recognize that both parents, the mother and the father in domestic violence situations, regardless of who is the perpetrator and who is the victim, are more likely to commit physical abuse on children than in other households where there is no domestic violence. Furthermore, sexual abuse of children is more likely to occur in a domestic violent household by the father. So the husband who is violent toward his wife may also sexually abuse his daughter. And outside of the home, those same children are more likely to be sexually abused as well. This may be related to the next bullet, in that in domestic violence, the mother is quite depressed and unable to attend to the child's needs. Those children are typically neglected emotionally and physically. This includes lack of supervision and not necessarily having someone they can go to for help, which makes them incredibly vulnerable inside and outside of the home. Witnessing domestic violence is viewed as a type of psychological abuse of children, and we'll talk more about psychological abuse later in the semester. What that is in addition to the physical aspect and the sexual abuse risk, witnessing can be psychological abuse because children are very scared, and that is the form of abuse that we call terrorizing. In addition to being in the middle physically, children are often yelled at, threatened, manipulated, and triangled into the parental relationship, with both parents, either party, trying to get the child to the right side of the parental conflict to support them. These are some additional ways that parenting is impacted by domestic violence. Both parents are more irritable. They tend to be inconsistent between each other, so they tend to disagree about child rearing. And because the mother is disempowered, particularly when the father is there, they tend to parent differently when the father is not there. So this produces inconsistency in the maternal parenting behaviors as well as in the relationship between the mom and dad. As I mentioned earlier, mothers who are victims of domestic violence are typically anxious, depressed, they've been undermined, and therefore they are less responsive to their children, they're less warm, and they're less able to assert authority and control. This element, the inability to assert authority and control, which is the demandingness we spoke of earlier, often leads to antisocial behavior in children. In these situations, children are at incredible risk for developing long-term difficulties and problems with authority and following rules. In addition, in domestic violence situations, there is less of an overlap in parental roles. There's typically sex role stereotypes that the father is responsible for this and the mother is responsible for caretaking the children. So parents are not working in a collaborative way, which is really the ideal situation for parenting children. The question of the effects of domestic violence on children is definitely a complicated one. It certainly raises theoretical questions related to the research. The first one is when we look at the effects of domestic violence versus exposure to marital conflict without violence, are the outcomes the same? The findings on this in the literature have been mixed. It is very, very clear that it is not a good thing to be raised in a household where the parents are in constant conflict, whether or not there's violence. So when the research suggests that children do poorly when they're raised in a home with domestic violence, it's hard to know if this is a result of the violence or a result of the conflict. Secondly, it's hard to know about the extent to which the effects of domestic violence are really in response to domestic violence or because there's so much child abuse present, and also the neglect that we spoke of, the physical abuse, the sexual abuse. So when we see in the literature that domestic violence produces XYZ effect, is this because the children has also been neglected and the children have also been neglected and physically and sexually abused? We also have to remember that most studies that have been done on the impact of domestic violence on children are conducted on children who are living in protective shelter with their mothers. This is a particular population of individuals who also may have other issues, particularly because of the many abrupt and sudden changes in their lives. They've been moved out of their homes, they no longer have contact with their fathers, possibly no longer have contact with their extended families for safety reasons. They also may have moved schools, and they also might be living in a community with other people who may or may not be supportive. In addition, they might now also be involved in the criminal justice or family court system. So it's hard to know whether those children who are a subgroup of children who are victims of domestic violence, it's hard to know if we're looking at the impact of domestic violence, the results of living in a shelter, or the additional issues that impact families living in an environment and as a result of the changes that have been made. In general, though, the literature suggests a tremendous impact on children of domestic violence, and the impact being the greatest on a younger child. Their coping is poor, their parents are unable to comfort them, they're more dependent on that parent, so they often develop attachment-related problems. Young children cannot just leave the home and go to a friend's for an escape. But what the one buffering factor for young children is that they may not fully understand the interaction between the batterer and the victim. If they pick up the mother's anxiety and tension, which they can do, it will certainly have an impact on them. But if they cannot understand the interaction or the language, and the mother may not appear distressed, many of these women are incredibly strong emotionally, it may not affect them as much. In children, we see what is called both externalizing and internalizing behaviors. Internalizing problems are just that, what the child experiences inside, such as depression and anxiety. Externalizing behaviors are problems that children exhibit to the world, and these are usually distressing to others. For example, aggressivity, which is a major problem in children who are exposed to domestic violence, is an externalized behavior and leads to long-term risk. We also see the physical effects of children who do not thrive. They don't eat well, they don't sleep well as a result of their anxiety. They have incredible problems in school and problems with their peers. And further along, there is long-term confusion about the meaning of love, whether violence is a part of intimacy and love, and also conflicts regarding culpability or who may have been to blame in the relationship. It's also important to notice that there are gender differences with higher rates of aggressivity among boys, the externalizing behaviors. This may be displayed directly towards the mother and ultimately in their own relationship. Some call this the identification with the abuser. Girls tend to experience PTSD and depression. Again, this may be a result of the identification with the victim, mimicking the parent, or in general, how men and women respond to stress. So there are two major practice issues and dilemmas related to children in domestic violence situations which are important to consider. The first one is whether victimized mothers should be held responsible as not protecting their children from the impact of domestic violence. This is incredibly controversial in the field. Very often, we go into the situations and ask the mother to put the father out, to move out, and to make difficult decisions in the relationship. These women are usually incredibly dependent on men financially and emotionally. They've been isolated, stripped of their resources and their support network. They also may be incredibly fearful of the perpetrators. And we know that the issue of lethality, of a woman being killed, is increased when she tries to leave the relationship. So one of the big problems is, how do we get help for the children at the same time that we do not re-victimize the mother? This has been a huge topic of discussion and has included some lawsuits, including a class action suit in New York in which Child Protective Services had removed children from mothers who they deemed as being non-protective. These mothers had been victims of domestic violence, and ultimately they were reunified with their mothers. And again, this remains a huge dilemma in our field. If you feel compelled to begin a discussion thread on this in the Cyber Cafe, that would be interesting to see what others think, particularly those who are working in Child Protective Services and have had direct involvement with these cases. The second practice issue is whether domestic violence should be considered in custody and visitation decisions. The mother, once they're separated, often requests supervised visitation based on the history of domestic violence. Typically, the courts, if there has been no direct violence on the children, permit liberal, unsupervised contact of the abuser with the children. Unfortunately, there's no consideration for the controlling characteristics we spoke of earlier, which goes beyond the direct physical contact to the children. So children exposed to that really does raise the question of the appropriateness of the father or the perpetrator and that individual's child-rearing behaviors. So one really should not be basing decisions on whether or not there has been direct abuse to the children by the perpetrator. It should be more about those other chronic dynamics. Now we're going to talk about parental substance abuse, the other major area of microsystemic risk factors. We talk about the fact that, first of all, substance abuse in parents produces an accumulation of risk. There is the risk of the actual substance use and abuse, the risk of people that the parents associate with, financial resources that are primarily spent on the addiction, as well as the communities that they live in. Parental substance abuse has a direct physical effect on children in terms of their caregiving capacity, although there is some controversy around the last bullet. So the accumulation of risks includes unemployment, lack of a high school degree, reliance on public assistance, homelessness, a variety of legal problems, including placement of children related to the severity of substance abuse, and there's a lack of social support, typically little relationship with the father of the children, and the parents' own parents may have a history of substance abuse. As we know, substance abuse is genetic. There has been some research that has proven this. 1 in 4 families are affected by substance abuse. There's physical impact on children. They can be higher rates of asthma, hearing problems, and vision problems. This could be related to lack of prenatal care or lack of infant care and wellness appointments. One of the factors we pay a lot of attention to is prenatal effects of substances in terms of risk factors for children. As a professional who works in the field of addictions, I think it is very important to remember that addiction is not a choice. Addiction is an illness. It's a chronic, progressive, oftentimes fatal illness, and it changes the chemistry of the brain. And so over time, The brain is literally hijacked and is starving for the substance of abuse. So people who in their heart and in their morals and beliefs are good parents and protective parents and love their children are controlled and dominated by substances and are making decisions to maintain their addiction, the best interest of the children are left at bay. One case in particular that I have worked with, the parents who were IV dependent heroin users left their child, young child, a 1.5-year-old, with a known sex offender while they were off obtaining and using their substance of choice, which is heroin. But back to alcohol. So again, I'm just saying that because you have to suspend judgment here when it comes to addiction and substance abuse. It doesn't excuse the behaviors, but we need to look at these parents and the illness that they are suffering from and get them the appropriate treatment and support possible. Back to alcohol, all the drugs that a pregnant woman can take, alcohol is the one that's most documented in terms of its negative effects on children. It's not clear how much alcohol should be taken. The March of Dimes says no alcohol is safe during pregnancy. Interestingly, obstetricians will tell women that they can have a glass of wine here or there. I continue to be shocked by this information, considering what we know about birth defects and what the March of Dimes has reported in terms of the fact that there's no safe use of alcohol. It's also different for each woman, and it depends on what stage in the pregnancy that they might be drinking alcohol, and also how much they're drinking. Alcohol use could lead to fetal alcohol syndrome. This is a significant syndrome, which is typically identified by abnormalities in the face, severe intellectual impairment, developmental delays, neurological problems, a small head, and a low birth weight. However, there also is fetal alcohol effects, and this is more subtle. It could be slight intellectual impairment. It could be neurological problems, learning disabilities, inability reading social cues. Sometimes these are individuals who suffer from fetal alcohol effects, and I actually am working with a woman right now where I am pretty certain that is her diagnosis, though it's unsure to tell certainly because she was adopted, and though they have information that her biological mother was in fact a drug user and an alcoholic, the information they received in the context of the adoption was that she was abstinent during pregnancy. But in order to confirm a diagnosis, you have to be able to confirm that there was alcohol use during pregnancy. And anyway, these are people who they just don't seem to get it. They'll look at you and they'll tell you that they understand, or that they're going to change their behaviors, or yes, I'm going to follow through on what I said, and then they turn around and they don't do it. It's not that there's a lack of empathy or disregard or even antisocial attitudes or behaviors. It's really that they just don't get it. Again, this is very subtle but has very profound impact on individuals and often goes undiagnosed. I believe that many of the individuals I work with in the addictions field might in fact have fetal alcohol effects, but again, it's just no one is ready to willing to admit that they used alcohol during pregnancy. It's a very difficult disorder to identify and to treat as well. Compared to alcohol, the literature is much less clear on other addictive drugs. Heroin and crack can lead to addiction in babies. The babies will be born dependent on the substances, and they will go through withdrawal, which can be incredibly sad and painful for babies. In addition, some of these babies may have contracted HIV because of the IV drug use, which has led to mothers contracting HIV. You might be surprised to learn that the literature is not clear at all whether these addictive substances have long-term neurological effects the way that alcohol does. In the early studies after the crack cocaine epidemic in the 80s, it definitely seemed to suggest that these children will have long-term neurological effects. It was later discovered, though, that these children were not removed as infants, so as they came into foster care later in their young lives, they had been raised in very chaotic families as a result of the substance abuse. So these studies didn't differentiate from prenatal and postnatal effects of substance use and abuse. But what we do know is that often women who are addicted to drugs, heroin, crack, cocaine, they do not get prenatal care, they don't eat well during their pregnancy, and children are often born with a low birth weight, which in and of itself can lead to medical and neurological difficulties. Women who use drugs postnatally after the child is born and breastfeed their children can pass the drugs to their baby. However, the most harmful effects are the ability to parent. The ability to parent is greatly affected. Women who are under the effects of drugs and alcohol are dulled, they're sleepy, they're not responsive, there's an incredible impairment in attachment. I'll tell you that as a mother myself, when my children have woken up in the middle of the night, whether they're sick or they're having a bad dream or they're just crying and need me to be there for them, I've often reflected on how sad it is for infants and young children who are in families where there's substance abuse, where the parent might rationalize that they put the baby down to bed and now they're going to get drunk or get high. But if they're passed out or blacked out or unable to respond to their children, those children are incredibly neglected. In addition, the parent is not able to protect the child from people who are in and out of the house. Also, these individuals who are engaging in substance use might also have a negative influence on the children, and mom is unable to step in. There's a complex relationship between drug use and parenting practices. The attitudes of substance abusing women typically do not differ from non-substance abusers who are in similar life circumstances. However, as I mentioned before, the substance abuse interferes with the capacity to parent. They cross a line where their morals and values really are not prevalent anymore because the substances have taken over, and their brains being starved and their bodies withdrawing from substances drive them to continue to use. So substance abuse doesn't tell us about their attitudes toward parenting, but it does tell us how their behaviors are going to affect kids. There's often preoccupation with drug use. The resources are funneled to support their habits. Sometimes women will even engage in prostitution to support their drug habits. The parent's physical health and emotional stability deteriorates, and the parent's availability to children and ability to protect is diminished. It's very important, though, to disentangle the capacities for parenting from their actual behaviors. A woman who enters recovery might not necessarily need parenting classes. She might be able to quite ably and capably parent when her drug of choice is no longer prevalent in her life and she receives the very positive emotional support that's available to women in recovery, particularly in 12-step support groups. It should be noted that the goal of reunification can be a powerful motivator in somebody's recovery process. And again, you really need to explore further whether the person with a substance abuse history who has maintained abstinence and is engaged in treatment can adequately parent their children. It has to be explored further. There's a very high relationship between mental health and substance abuse. We call this co-occurrence, co-occurring disorders, formerly referred to as dual diagnosis. Although men also do have a high instance, it's much more likely to be true in women. The combination of the two problems leads to a significant high level of impairment. Co-occurrence or dual diagnosis is also associated with high rates of homelessness, loss of custody of children, child abuse of children, and domestic violence. So you have to ask yourself the question, why? Why are women more vulnerable? Typically, women are more vulnerable to experience PTSD, and drug and alcohol use is essentially self-medication. When someone is high or drunk, they do not experience anxiety, they have no intrusive thoughts, flashbacks are gone. Initially, when people enter recovery and they're abstinent from substances of abuse, PTSD symptoms will return. If they don't have the proper support and treatment, they will relapse in order to self-medicate. Some substance abuse professionals will not be able to provide this appropriate support. There are certified addiction counselors who are knowledgeable of PTSD and of providing support. However, unless they're a licensed mental health professional, they won't be able to provide the treatment needed for someone who suffers from PTSD, serious depression, or serious anxiety. Um, ideally, Ideally, we would refer these clients to somebody who has both a mental health license and also a specialty in addictions. In New Jersey, that would be a licensed clinical alcohol and drug counselor, an LCADC, which is typically somebody who has a mental health, a master's degree in a mental health or related field, and also has been licensed as a alcohol and drug counselor as well. We find that many of these women's traumas were actually child abuse. It appears that the abuse and the mental disorders, the child abuse and the mental disorders actually precede the substance abuse. PTSD and depression typically develop in adolescence. And we know that is also right around the time when people start to experiment with substances of abuse. While we do see progressed addicts in adolescence, you typically see people who are abusing substances who have not necessarily moved towards dependence on substances, though that is very possible by the late teens and certainly by early 20s. Again, I don't want to minimize that adolescents can't be truly addicted. They certainly can, but they are typically not as far along in the continuum of addiction as someone who's a little older. In addition, the presence of co-occurring disorders makes a woman at greater risk for continued victimization and interpersonal violence. We'll discuss this more later in the semester, and this will lead to almost a cycle of post-traumatic stress disorder, depression, leading to more progressed substance use disorders, and a real entangled web that is very, very difficult to treat, but incredibly possible as well. Finally, let's talk about ontogenetic factors. This is to say that children bring their own risk factors into a child rearing situation. This is not blaming children, but we do need to be aware that certain kinds of children and certain kinds of situations can raise the risk of abuse for a child. For example, developmental stages. We know that infants are at a high risk of child abuse because they're very demanding and they're very needy. They cry often, they need to be held, changed, and fed. Very young infants are not engaged in back and forth emotional connection or social connections until about 3 or 4 months old. And moms can be experiencing baby blues, postpartum depression, and incredible high stress. Also, children who have disabilities are at a higher risk for the same reasons. They're more demanding, they need more attention, and they might take longer to learn things. Children who are temperamentally easily frustrated are also at higher risk. You'll often see these parents get into power struggles with their young children, the spirited child, if you will, and that can lead them to higher risk as the parents become more and more frustrated and utilize physical discipline or corporal punishment to try and establish rules and boundaries with the spirited child. The last two bullets are particularly important to remember because children may have behavioral problems that may or may not be related to histories of trauma, but once you have a history of attachment problems, this will lead to behavior problems. Those behaviors will often trigger further incidents of abuse, which will exacerbate a trauma reaction. So you're really looking at a cycle for these young kids. They're difficult growing up. As a result, they're abused. They develop trauma symptoms, which leads to increased behavior problems, which leads to increased abuse. And other parental limitations, you really need to look at what are the needs of the child, especially if there's disability. I have to say that early intervention services in New Jersey are an incredible resource for families. It's barrier-free. They will provide services in the home or where the child is during the day and can assist with children who are showing red flags or developmental delays. Resources also need to be made available to parents, particularly parents that struggle with spirited children or easily frustrated children. And children who have disabilities. Sometimes parents need a break. Sometimes they need some respite. and they certainly need to understand their children, their diagnosis, their symptoms, but more importantly, how they can provide support to them. This concludes this lecture. Please feel free to post any questions or comments in the Cyber Cafe. Thank you.